decision in a multidisciplinary meeting, and then to give the information to the patient and to assess his psychological will. So looking at the unruptured intracranial aneurysm on the right side, we should treat large and wide neck aneurysm, maybe some anterior circulation, recanalization after failure of endovascular treatment for young people, of course. So this is a monocentric series from 2009 to 2021, around 200 aneurysm. Most of them were middle cerebral aneurysm, and we perform a complete occlusion in 90% of them. And the purpose of this study was that we assessed each aneurysm. After each clipping, we assessed the patient and the brain with a postoperative MRI, which was performed within 5 days. So the purpose was to assess the brain. So this is an arterial assessment. Usually, of course, the diffusion sequences were normal in 90% of the case, but in 10% of the case, we had some hyper signal, which was a criteria for ischemia, either in the same territory for perforators, either in different territories. We have also a venous assessment. As you can see on the right side, the superficial frontal vein was sacrificed for any reason, and you have in the postoperative curves this edema and this hematoma, and this is the following imaging showing the decreasing of the edema and the hypersignal in flare. Patients have also postoperative, within 3 months they had a 2D TSA angiography to assess the quality of the extrusion of the aneurysm, as you can see. So what we found in multivariate analysis was that the prognosis was worse and the rate of ischemia was worse with the higher size of the neck, age superior to 60, and a short M1 less than 12 millimeters. So we don't find temporary clipping, previous embolization, or calcification as risk factors in this series. The follow-up was no mortality, and the morbidity, again assessed by a neurologist, was the MRS 0 to 2 in 90.5% and MRS 3 in 0.5%. So let's talk about a few words about the basic principle for aneurysm surgery. Arachnoid dissection, as you can see, sharp dissection to avoid any brain manipulation, of course. Same principle as for skull-based surgery. So you may drill the bone to decrease the brain retraction, and you use retractor either with caution, either you may not even use some retractors. Vein, of course, has to be respected, especially the superficial sylvian vein. You may check for proximal control of the parent artery, control of the efferent arteries, dissection and of the complete dissection of the neck to try to obtain the best clipping possible and the highest rate of exclusion. Some illustration. This is 56. It's already finished. I have a few minutes. Okay. It's 56. Unruptured aneurysm. You can see, I won't show the video, with this postoperative DSA, as you can see, with a complete cure, and this small branch exiting from the sac was preserved. And this is the nice thing of surgery, is that you may reconstruct the bifurcation and you may respect a perforator or a branch exiting at the level of the sac. More complex cases with atherosclerotic aneurysm and atherosclerotic wall. This is, you can see that this is yellow and all atherosclerotic, and this was managed, but as you can see on the postoperative DSA, the extrusion rate was not complete in this case. A case of recanalization after embolization. So you have to assess the size of the recanalization to be sure that you will be able to place the clip at the base of the at the neck of the aneurysm. So it has to be done on the 3D DSA and on the 2D DSA. And you may use some beautiful reconstruction, as you can see here on this picture. And once again, this is the postoperative control with a complete extrusion of the neck and an assessment of the brain with no hyper signal on the flare sequences. Last example, recanalization, end of the internal carotid artery, distal. There was a growth on the follow-up, and we decided to clip this aneurysm. I had an issue with the perforators, and the patient was fine with no deficit postoperatively. This is the MR which was done at D1, and you can see that there was a sacrifice with an ischemia on the head of the caudate nucleus. So this lesion, if you don't do postoperative imaging, you may miss this lesion. And this is very important to see this lesion, because you may see again your video and you may improve yourself for the next patient. As a conclusion, surgery for unruptured intracranial aneurysm remains a safe and quite efficient treatment strategy. These are complex cases, and experience is needed because these are large aneurysm, atherosclerosis, and recanalized aneurysm, which is quite difficult. And again, if you want to counsel your patient, you have to assess your own result. That is to say, the result of the surgical team in your department and the result of the interventional neuroradiologist also in the hospital. Thank you very much.
Thank you, Mr. President. I call our friend Mr. Michel Bujanowski, speaking about the meta-analysis of E1 segment of the anterior cerebral artery. Very rare, the A1. We treated 3 in our series, 1 before Opener, and 1 after Opener artery, and 1 just in the connection with the A2. So it's very rare, and I'm very curious to listen to you, Michel, to know which curiosity you should show us. Thank you.
Okay, so the purpose of this lecture is to discuss a type of aneurysm that is not often seen, but for which you need to be prepared when you do encounter it. It is a sidewall aneurysm, an aneurysm that does not originate from a bifurcation. Although the topic will deal with aneurysm of the A1 segment of the anterior cerebral artery, this is not the only location where these aneurysms can be found, nor is it the most common location. It is important to recognize that in some of these that in some of these sidewall aneurysm, the intraoperative risk of bleeding is very high because of their pathophysiologic formation. So there are two kinds of aneurysm: those that arise at a bifurcation and those that are not. Those that are not are called sidewall aneurysms or lateral wall aneurysms. From a hemodynamic point of view, the mechanism of formation is different from the two types of aneurysms. Sidewall aneurysms on your left are located on the lateral walls of the arteries. The afferent and efferent flow is on the same vessel. The flow jet typically impinges first on the neck of the aneurysm and rarely at the dome. On the other hand, in a bifurcation aneurysm, the blood flow from the afferent vessel splits into two or more efferent vessels. The blood flow jet often impinges directly on the dome of the aneurysm. Disturbances secondary to the hemodynamic stress on the artery wall can lead to two types of sidewall aneurysm: a berry-like aneurysm on your left side, and blister or dissecting aneurysm on your right side. The difference between the two is that the blister aneurysm has no real neck, because the wall of the parent artery is also diseased and is a site of a hemorrhage, as you can see on your left drawing. You realize that clipping such an aneurysm may be disastrous if the surgeon is not prepared and does not recognize the possibility during dissection of the aneurysm or before applying a clip. You can see here A1 aneurysm, clipped, and because there is no neck and the wall is also diseased, when you clip this kind of aneurysm, you need to take a part of the wall of the artery. So neurosurgeons are much more aware of these aneurysms, this kind of blister aneurysm, in the supraclinoid segment of the internal carotid artery, but not so in the more rare cases involving the A1 segment of the ACA. The nuances in the surgical treatment of blister aneurysm of various morphologies have been described. So we made a systematic review of the literature and a meta-analysis using the PRISMA guidelines. After having eliminated, the goal was to determine the epidemiologic aspect of a patient with A1 segment aneurysm of the ACA, to study their morphology, to analyze the treatment modalities, and to study the outcome, the clinical outcome with this patient. So the inclusion criteria was clinical reporting observation in human subject, A1, all A1 aneurysm morphologies, all article with abstract in English or French. You see here the exclusion criteria. After eliminating those who doesn't comply with the inclusion criteria, we remain with 73 cases, based on 131 articles from 1904 to 2019. So there were 714 A1 aneurysm, and the age was, as you can see, the mean age was 52. there was a little predominance of women, and most of these aneurysm bled. Oh, you don't. Okay, excusez-moi. Can you hear now? So if I approach to my computer, is that okay like this? Okay, thank you for telling me. Okay, so the aneurysm characteristic, you see here more often there were proximal aneurysm, and in the middle is 10% and distal 20 something percent. Most of these aneurysms were ruptured. Most of these aneurysms were small. They were small aneurysm, and most of these aneurysms were not blister or dissecting aneurysm, but were the saccular type of aneurysm. Okay, so the size according to the rupture, as you can see, when the very small aneurysm were less likely to bleed, but still small means very tiny, because after more than 3 millimeters you can see how often they can bleed. So the characteristic according to morphology, you see the age of these aneurysm with fusiform or dissecting type of aneurysm. The patients are much younger than what we see usually for regular berry aneurysms. So the dissection occur in young patients. The associated vascular variance is like for all others aneurysm, saccular aneurysm, and we can see here the treatment modality. Most of these patients were treated in this series by surgery, but with time, we can see that the endovascular means take more and more place in the treatment of these aneurysms. So when the aneurysm is on rupture, these patients are more likely treated by endovascular means, and it's different, and it's the opposite for when there is something. My computer moved. Okay. I'm sorry. Okay. So the treatment modality, according to the size, when the aneurysm is very small, it is more likely to be operated on. So what is the functional outcome? Most of these patients had a good recovery, but most of them were the saccular type of aneurysm. The bad outcome was mostly on the dissecting type, like blister aneurysms. And you can see that with medical, at the last row, with the medical treatment, most aneurysm rebled. And in fact, we know that the risk of these blister or dissecting aneurysm, the risk is much higher than the others. So in conclusion, the majority of aneurysm were on the saccular type, not blister. Their clinical and morphological characteristics are comparable to bifurcation aneurysm of the anterior circulation. There was a significant proportion of blister aneurysm, 12%. Elsewhere, for the carotid, for instance, it's about 1%. Here for the A1, it's about 12%. Patient with these blister aneurysm had a less favorable prognosis. So this means that when you encounter an aneurysm on the A1 segment of the anterior cerebral artery, it's not always very obvious by angiography to recognize that this is a blister aneurysm. But if you decide to go by surgery, you have to be prepared, because in 12% of cases this will be a blister, and this means that they are very fragile, and they can bleed easily during the dissection or when you decide to apply a clip. But this doesn't mean that the rate of complication is less by endovascular means, because as I told you earlier, the problem with these aneurysms is that the artery is also diseased, and you have a hemorrhage inside of these in the wall of these parent arteries, which make also the endovascular treatment difficult. So the limitation of the study, of course, is the data in the literature is not standardized. There are many missing data. In the future, needs to randomize studies to determine the best therapeutic modality. Thank you for your attention.
Thank you very much, Michel, for this interesting study. I call Professor Al-Khamlishi. For the next session is evolution of cerebral aneurysm management in Africa. Professor Al-Khamlishi, please.
Thank you, dear colleague. It's my pleasure to participate in this session, and of course, myself also thanking the organizers for making me participating in this vascular session. You have heard from outstanding and famous colleagues about different ways to manage cerebral aneurysm, either by microsurgery or by endovascular, ruptured or not ruptured. I will not maybe tell you so much on the techniques, but I would like to tell you some history, how this cerebral aneurysm management evolved, especially in Morocco, describing you my way in introducing this surgery, and also in Africa and worldwide very quickly. I think that our young colleagues here, especially those who were trained in WFNS Rabat Training Center and are back home, they are of course facing the challenge to develop this high technology of subspecialty. So I think that it's important to show us how maybe to manage to do it. Cerebral aneurysm management has been developed in the starting by the half of the last century, thanks to two progresses. First one is the increasing number of neurosurgeons, and the second one is, of course, the imaging technology. And this was the case everywhere, even in developed countries. And you see here, for example, on this slide from Japan, that it started, the modern cerebrovascular surgery started in the 60s, and she progressed very, very quickly by the 70s, 80s, thanks to the arrival of the microsurgery and the imaging technology. However, in addition of the technology and the neurosurgical workforce, there are some many other factors who delayed the development of this surgery in different places, mainly in developing countries and in our places. And one of these reasons was, at that time in the 60th, 70th, this common belief of low incidence of cerebral aneurysm in our regions. And this belief was really rooted in the mind of many of our pioneer neurologists and neurosurgeons, not only in Africa, and they wrote a lot about that. Look, this paper from the famous pioneer neurosurgeon late Odiku in Nigeria, describing the rarity and the inexistence of aneurysm and giving some causes. Another one also by a very famous neurosurgeon, Ramamurthy, the pioneer of neurosurgeon in India, stating the same. This one from the Chinese colleagues in Hong Kong, and this very provocative article from two famous neurosurgeons, well-known, Osama al-Mifti and John Fox, when they were working in Saudi Arabia by the 80th. Regarding Africa, in 1973, as a resident in my second year, I attended at this time the second Pan-African Association of Neurological Surgeons Congress in Dakar, Senegal. And I found our masters, neurologists and neurosurgeons, Africans, speaking about the rarity or inexistence of cerebral aneurysm in Africa. After having finished my residency in 1977, I had the chance to have 2-year fellowship in France and in Switzerland, and of course to witness two of great masters of this surgery, Ghazi Yazargil and late Robert Derouty in France, in Lyon. And I was astonished about the high number of patients they were operated. Back to Rabat in 79, I found the same situation, maybe one case or 2 cases a year. So as I took the head of a department in 1983, I wanted to challenge this belief, this common belief. And thanks to the support of 3 well-dedicated of my first resident, they helped to make an anatomical study on 250 brains, 100 adults, 100 children, and 50 fetuses. In this study, we used the injection techniques, classical technique, and we searched first for the morphology of the circle of Willis to see if in Moroccan population there is some hemodynamic and anatomic aspects who can explain this rarity or inexistence. And we look also to the incidence of cerebral aneurysm in autopsy series, and we found that it's not different from the ones which were published in the literature. So this is the slide. All of you know I was showing since more than 40 years, not only in Moroccan meeting, but in African meeting and everywhere, saying to the colleagues that the low incidence is a result of no awareness and no diagnosis of cerebral arachnoid hemorrhage, and we cannot increase the incidence if we don't look to this diagnosis. And you see the evolution of the number in the department in Rabat, at the Hôpital de Spécialité at that time. The number was doubling every 5 years, slowly but surely, until we reach, by the beginning of this century, 2009, between 45 and 50 cases a year in the department. And in 2000, we published our first series on 200 cases, challenging this idea of the concept of their rarity and explaining that the main reason is the lack of the diagnosis, and that many of these patients die before arriving to the hospital. Look just this slide on the origin of our patients. At that time, we have just 22% of patients coming from a rural area, whereas the majority, 80%, coming from the urban area. At that time, in the census of the population, the proportion between urban and rural was almost equal, 51% and 48%. And this is the increase in number until from 83 to 2018 in this epidemiological study who was mentioned by Professor Wahabi. And you see that the increase was the same, and we had at that time almost 1,000. I think that today it should be maybe 1,100 or 200. So the first challenge, if you want to develop this specialty, is first to convince the practitioners, neurologists, to make the diagnosis and to search patients with ruptured cerebral aneurysms. But the second challenge is to get them treated properly just after their arrival to the hospital. And this is the most important thing. You need a collaborative multidisciplinary team, especially the neuroradiologist and the intensive care specialist. And look, for example, I was very happy to see in all the series of my colleagues that there is no problem today to have the angiography in day 0 or in day 1. Look, it took me 20 years from 1983 to 2005 to convince our colleague neuroradiologist that this angiography should be done in emergency. In 1983, just 1/3 of our patients could have their angiography before the day 1. And after 2005, by chance, now more than 90% can have this angiography. So this multidisciplinary, dedicated team is very, very, very important. Of course, the most important in this multidisciplinary team is the neurosurgeon. So you have to train the colleagues who are surrounding you. They have to know how to operate them safely. If you want that the practitioners and neurologists, and you know the neurologists, how they are following the results of neurosurgeons. So, of course, it was necessary to start to teach them how to open, to make craniotomy, or many things were done. I would like just to add that these two legendary techniques and craniotomy, the pterional one was introduced by Ghazi Yazarjil, and the frontolateral one by Majid Sami. And now, of course, they are so popularized. And then you teach them also how to open the Sylvian fissure, the highway to the arterial circle of Willis, and of course, the highway to find the aneurysm, to dissect it, and to clip it. Starting, of course, by showing them the most simple, maybe, aneurysm, and you are behind, as was said by Professor Azhari. And this is a case of a posterior communicating artery. You see that you arrive quite quickly, and then you can put your clip very easily to avoid, of course, here it was done, the collateral arteries, mainly the choroidal artery and the posterior communicating artery. They have shown you all this. Here, another very simple way, one also, the bifurcation, the carotid artery bifurcation. I can go fast because you have seen all that, and then you go to some who are more difficult, the carotidophthalmic aneurysm, as you see here, where Dr. Wahabi has shown one case or two, I think. You have to put a temporary clip, dissect your sac, and then resect it, and of course adjust your clip to avoid the compression of the carotidophthalmic aneurysm. You see here the removal of the anterior clinoidal artery. This was my first case, operated in 1983. And of course, to start to show such cases to the practitioners and neurologists, you can be sure that they can send you later on your patients. Then the other, I will not, all that was already said to you. All locations, they have to learn how to do them, and especially those who arrive in urgence with such large hematoma, where of course with some experience you can evacuate the hematoma and you can clip your aneurysm. The third challenge was to develop the endovascular techniques. Since 1983 into the beginning of this century, 2005, all aneurysms were treated with microsurgery. By 2005, we started to have the endovascular technique practiced by first one a neuroradiologist in our hospital was Professor Hassani. All of you know him. And then he trained also some one or two other radiologists. But it was very important for me to try to have in our country an hybrid neurosurgeon. And this is the reason I started first to converse, to have the acceptance for that by the neuroradiologist, because it wasn't not easy to introduce a neurosurgeon to make endovascular technique. By chance, we succeeded to do that, and you have seen in the last session, maybe she's going to present you something today or tomorrow, Dr. Mahjouba Boutarbush, who is now either operating aneurysm and also treating them with endovascular. And I must say that she's doing very, very good work. And this is also a way for us, I think, to make endovascular techniques progressing. There have been a lot of discussion between our colleague Wahabi, Miguel, and others regarding why this difference in endovascular and microsurgery in between Europe and our places. For me, I think this is an evolution, is a natural evolution in this pathology. Between 1970 and 2000, in Europe also, the microsurgery was dominant because neurosurgeons had the preference for this treatment. But the endovascular came quite quickly, and they are progressive. So I think that we will see the same situation in our place in the future. So it's very, very important to have, I think, neurosurgeons participating in this endovascular technique. Anyway, you have also seen all these results. And you see here this slide on these statistics, which was made by Abd-Samad, Professor Wahabi. You see that before 2005, our 451 aneurysms were all clipped, as I said. And since that, until 2018, the other 492, almost half, 500, were treated 2/3 with microsurgery and 1/3 with endovascular. But I am afraid that this will change in the future. So I see that my time is finished, and I would like to conclude by just saying two important things. I am personally very happy to see the evolution of vascular neurosurgery in Morocco, and to see it also evolving in Africa, because in the last 2 decades, in different African neurosurgeon meeting we see many series of cerebral aneurysm treatment, mainly operated, coming from different African countries. And this is very, very important, I think, a result of this work. Second, I think that, or I hope that this history will be used by many of our young colleagues who are today trying with all their effort to develop neurosurgery in their countries in sub-Saharan Africa, and of course after having developed the general neurosurgery, they will face, of course, the development of the vascular surgery, mainly aneurysm surgery, and I hope that this will serve for them in their career. Thank you. Oui. Hey, pardon.
Professor Hamdishi, for this travel in the past and in the future. And all the time I tell to my colleagues that we are lucky to live. I think 2 or 3 generations will live this gap from surgery to endoscopy to endovascular to hybrid, and I don't know in the future which name we will give to the next neurosurgeon. Perhaps they do other things, and it should be hybrid and other things. And it's really very interesting to live the history in the Morocco, in the Africa, because when we started avec Professor Bouzouba, Dr. Bouzouba, and Dr. Aziz Alawi in Casablanca, there was angiography, but there was no CT scan. So it was really curious. 3 paper, very interesting paper, and we will start the discussion. For the first one by Dr. Professor Bresson. Have you some question to first the first one?
I had a question to Professor Bresson. First, thank you for your presentation. I just wanted to know if you have a special screening policy for these unruptured aneurysm, or are they still like incidental findings? So do you apply a special screening protocol with your radiologist or with in your hospital, or are they still incidentals?
Thank you for the question. We don't have a special protocol. We essentially recruit like incidental aneurysm. Very few specific disease like polykystose and some other, but otherwise we don't do screening. And I think that screening, except for patient who had 2 relatives with previous hemorrhage, I don't think that screening is recommended in the literature.
Thank you. Other question?
Another question for Professor Besson. Do you treat patient with small aneurysm? I mean, less than 6 millimeters.
7 small aneurysm.
Of course, unruptured.
Yeah, we don't. As you may see, the series like 200 was for 15 years, so it's a very low number of aneurysm a year. And we used to work with in a very well and a very famous hospital with a very historical center of intervention neuroradiology with Professor Oudar. And we are very careful for the indication, so we don't treat aneurysm less than 6 millimeters usually, and 80 to 90% of the aneurysm when there is an indication to treat or embolized. So there is very few aneurysm for surgery, but that's the explanation for the higher complexity, because these are large aneurysm or recanalized aneurysm, and not very small aneurysm.
But were you talking about surgical treatment, or you were talking also for endovascular? Yes. Do you treat?
So the first question in our multidisciplinary team is either treatment or not treatment, and then first answer, and then we decide for the embolization or surgery.
So for the first question, if the aneurysm is less than 7 millimeters, you rarely treat these patients.
Rarely. And I suggest a reading. Emmanuel Houdard and his team, they published, because I don't belong anymore to this team, I moved a few years ago, but he published a nice paper on the follow-up of unruptured aneurysm that were untreated. A very nice paper with a very low rate of secondary hemorrhage during the follow-up.
Thank you very much for your nice presentation. 2 questions. First, what in your daily practice, the percentage of unruptured aneurysm versus ruptured aneurysm you see in your practice? The second one, it's very interesting to show what after surgery you have some modification on MRI. Did you see something like that in the endovascular group? Did you compare?
Thank you. That's true that when any patient who have an angiography, and especially when they have a treatment like coiling, if you realize and if you perform magnetic resonance imaging just right after, within 5 days, you will see some spot in both hemispheres because of the catheterism. So that's quite common. And we didn't compare in our theory. And the rate of ruptured versus unruptured, ruptured are usually embolized in our department. So 95% of ruptured aneurysm are embolized. So I did one last week, but it's very rare. It's because of a huge hematoma.
Professor Aitminali, there's a lot of question for this. Professor Aitminali, after Professor Butarbouch.
I would like to thank all those speakers for their...
Sorry, Professor Aitminali, Professor Butarbouch, Dr. Bouzouba, and we start we go to the second presentation.
I would like to thank all the speakers for their very nice presentation. Professor Brisson, you said that as a neurosurgeon we are good, but not as good as we think. And you showed us several MRI imaging demonstrating brain infarct and so brain edema, etc. Do you perform neuropsychological assessment for these patients?
Thank you very much. It's a very good question. Unfortunately, not. They don't have neuropsychological evaluation. But again, we should do it. Definitely, we should do it.
Professor Butarbouch, Juba.
Thank you. I want to raise a question about how we can. I was once supported and helped to perfect my practice of cerebrovascular neurosurgery with the help of my seniors, Professor Khamlishi, and then the whole team of the department I started in and I am still in now for 20 years. Very lucky I was. For me, having done the endovascular competence, endovascular practice, has helped me also to be to train easily in microsurgery also. It was very helpful. And now I want to raise a question. I want to know how we can help, because I have these questions all the time from the residents and from the neurosurgeons from around the all the cities in my country and also in neighboring countries in Africa, how we can do that. So my questions for the chiefs of departments, for the senior neurosurgeons, how can we do it again? Please, how can we do it again? Because it takes a lot of time to train in microvascular, in microsurgery, and it needs job offers in the university. This is, we know it. It took less time, obviously less time to train in endovascular, and there is a competency and there is a university diploma all in Europe, in France, as a matter of fact, 2 years. How can we help to help these colleagues, these younger colleagues, to train and to achieve this dream of having, the ability to treat this aneurysm pathology.
Thank you. Dr. Bouzouba.
Thank you for your presentation, Dr. Bresson. My question is, what's your answer to a patient who told you that he had a small aneurysm? Should I to be operated?
So what's the indication?
Should the small aneurysm, the risk of the small aneurysm is higher than a big one in a rupture aneurysm?
We are just referring to the data of the literature. We just apply it in the multidisciplinary team with the phase growth. So small aneurysm, young or 60, you have to deal with the age. Less than 5 millimeter, usually we will just wait on scan. And so we will see the patient, we will reassure the patient, because at the beginning, of course, he's very anxious, and then you have to offer the patient to see him once, to give him some information, and then he's very anxious, and then the second time, 1 month again, he learns how to live, and he can do again some sport and some exercise, and lots of people, they learn how to live with their aneurysm, and they are not scary. And I know, and that is the focus, and this is the objective of the paper. I think that we treat too many aneurysm. The rate of unruptured aneurysm is quite low, and we have some morbidity and some mortality that are related to our treatment. So we have to be very cautious when we offered a patient a treatment.
Thank you. We move in the second presentation with the question of Professor Boutarbush. Should we go to the third presentation, which is education? So with the presentation of Professor Michel Bojanovsky, I have just advice for young neurosurgeon. You have to read the embryology of the polygondoilis. It's very, very interesting, because the aneurysm of E1 is very rare, 1%, about 1%, I think, because the first artery made in budget 5 is the cerebral anterior, and the last one is the anterior communicating. That's why the anterior communicating aneurysm is more frequent, 40%. And it's very interesting to read that, because when the brain is started to function at budget 5, the heart start to work. It's about 20 days in the fetus. It's very interesting and amazing. So it's to understand the frequency of the aneurysm and the dysplasia and everything, the embryology can explain a lot of things. Is there some Professor Michel Bujanowski.
Thank you. Thank you. I would like to comment on the last comment of Damien, Professor Besson, when he says that we operate or we treat, not only operation, but we treat too many aneurysms. And I think the best way to change the practice of clinician, neurologist or neurosurgeon is to have a randomized study. And this is the reason why, this is a comment for Dr. Hamishi. In the late 80s, there was a randomized study, the cooperative study. And in this study, it reveals that most of the bleeding occurred, the highest rate of bleeding after a rupture aneurysm of free bleeding is for the first 24 hours. So if you want to change the mind of your colleague neurologist or neurosurgeon, this is the point. You need to explain, and this is the reason why the patient passed from late surgery to a very early surgery. And this was the same for the endovascular treatment. There was a lot of discussion prior to the result of ISAT study, but these discussion decreased a lot after the report of the ISAT study. So if we want to change something, we have to rely on the randomized study, and this is all over the world. If you have a good randomized study, you will change the mind of people, and okay. So that's the reason why most of my cases, AVM, aneurysms, rupture, non-rupture, are randomized in our unit. We meet every week with the endovascular team, surgeon or radiologist, neurologist, and we decide on site to propose to the patient to participate to a study. And I think this is the only way to have the best answer, to be the closest to the reality, and to change the mind of clinicians. Thank you.
Thank you. I want to thank Professor Khamlishi for this presentation, which bring us in our residana. And the question of Professor Butarbush is very, very interesting and very difficult. It's difficult to answer. You know why? Professor Khamlishi was the father of this surgery, vascular surgery. So when he started, he made a lot of study in Maghreb, in Morocco, and Professor Azouzi, Amrani, and Agdash started to do in the cadaveric to demonstrate that aneurysm exists also in Maghreb and in Morocco. And you know why? To answer, in my opinion, to your question, the 2 years you passed to endovascular, you don't waste it. Au contraire, you win a lot of knowledge about vascular. And when we started our interna, it was concours d'interna, and started our residana, we have both Professor Khamlishi, Professor Warzazi, and both of Professor Ammou and Mohammed Belghmedi, etc. We never think to private. We never think. We pass the concours d'internat to go to the university and to make research and to go and to be a teacher, professor. That is the first. It depends of generation. If people start specialty and want to do neurosurgery, you know, now spine surgeon is very fashionable. And a lot of young neurosurgeons love spine surgeon, mini invasive, etc., etc. And it depends. It depends of the father. The boss before was the father, the boss, the mentor, etc. And now the mentality is changing, and it depends of what you have as the follower. What kind of, how they imagine their life, if they have some goals in the life, if they want to go to the research, to go to the university, or to go to the private, to live normally. That is the question. But your question, you are lucky, and we are lucky in Morocco to have you. But it's the vision of Professor Khamlichi. It's very important. If there is nobody have a vision, sometimes you have to open the door, closed, to have some things for the country. Sometimes the politics don't aware about anything about that. They don't know. So the practitioners know. They know what they want, and they can go in this way. It depends of the team, pedagogic teams. That is my opinion. And it depends on the university, for example, in Morocco, in University, Casablanca, Marrakesh, Rabat, Oujda, Fez, etc. 9 universities, we have to have somebody in one university or in 2 universities to have a vision for vascular or for other. That is my opinion. But I think I want to listen to the opinion of Professor Khamlichi, because the presentation is in this way, Professor Khamlichi. And Professor Bouzuba after.
I think that the question raised by Mahjouba is maybe one of the most important, which should be raised by all other colleagues we have, mainly the young ones who are looking to have some subspecialty, how they can evolve in neurosurgery. And this is the reason I made this presentation, to try to show one experience, because no one has, as we said in French language, cuisine receipt. There is just the way you have followed to tell the others. I think that the answer of the question of Mahjouba is should be in 2 issues. The first one, you mentioned it, my dear Abd Samad. First is the dedication of the young resident or young assistant or young associate professor. He wants to do something, and he's decided, he took a decision. This is what happened with Mahjouba. If she didn't come to see me to say, I want to have a fellowship on endovascular, after she had maybe, I think, 8 years or around 8 years neurosurgery. This is the first. Of course, she needs, as you said, the support, our support. But this is, I think, it's our duty. I mean, the young people should not ask for. It's our duty. We have to support them. So I said, okay. But I told her, there is an important obstacle, because neuroradiologists have already started to make endovascular with some years. They are in position of chief of department in the hospital. Fortunately, we were working in a very, very, very good multidisciplinary team. And I told her, we have to discuss with them. They have to give us their agreement, because you are going to be trained there first with a neuroradiologist. And then when you will come back, you need to have a position at the university. And this position cannot be there without the agreement of the neuroradiologist. I'm sorry, I am telling that, because this is, I think, what you need for the answer, what the others should heard, the young, how to do. So I discussed it with our colleague neuroradiologist. Of course, it doesn't easier, but we succeed to say yes. Why not? I try to explain the scientific, the argument, the the positive, what will be the positive to have a neurosurgeon making also endovascular. And maybe I said, why not? One of you, if he wants to come to neurosurgery, why not? So it went very smooth in that way. She went for her fellowship for 2 years. She came back. She started to work with them. We succeeded 3 or 4 years later to create for her position at the university. Now she's professor. So I think we find one special position. She's professor of neuroanatomy, which is no neurosurgery, no neuroradiology, but both. And I think neuroanatomy was an excellent choice, because it's the most important basis of course, either vascular surgery, you were all telling us that this morning, and also endovascular. So this is, what we did.
Thank you, Professor.
There are maybe other ways to do it.
Dr. Bouzou, and after that, Najia. Hybrid surgeon, hybrid is very fashionable. So I think young neurosurgeon will want to go there in this way, because it's very interesting with hybrid.
I want just to say that adopting a new techniques or introducing a new procedure depends mainly on the needs of the patient. And thanks to Professor Hamlishi in 1980 to have looked for this for this problem at this date, because patient dead without being treated. So the patient needs should be our motor to improve or to introduce some specialty or some procedure.
Najia Abedi.
Thank you. I would have loved to say it's if we can compare this to the women in neurosurgery, because when we start as women in neurosurgery is the same. We need the pioneer, we need the senior, we need a leadership, we need a vision for developing this such a vision like Professor Hamlishi did with Bahjouba, and I hope now that the next generation after Professor Hamlishi and us, who are the senior, to have a vision for other subspecialties where we need at least to be in the same neuroradiologist or neuroanatomist or neurosurgeon. So now today, I think, Mahjouba, it's your duty to continue this work. Yes, I'm serious, because most of the time when we are in the university, our student, our resident, our intern told us and asked us, please, how come to promote neurosurgery? And the dean of the school, for example, how come to promote the neurosurgery, for example, by promoting by ourselves and proving that that female could be a good neurosurgeon. So now it's your duty to demonstrate to other neurosurgeons that to be in the same vascular neurosurgeon and endovascular therapeutic is possible, and you have to promote it. Thank you.
She said she wants to promote it, but people ask her how to do.
Now she
what about all the problems of the time, 2 years, etc., etc. Her question is very, very, very precise. It's very. I think if Professor Wahabi, Professor Ethmoidal, or our friend from Tunisia, or Kazadi, or Sanoussi have some comment about this question, because it's very important question. Please, you can have the mic. All head of departments should have idea about that. Tu veux parler?
I just want to make a resume, if I may. After having listening all this, I think what you are telling is, for regardless of the subspecialty in neurosurgery, the role of the faculty, the members of the teachers, the role is very important. Their role in offering and sustaining the opportunities for the young residents and the young training, the young neurosurgeons, because I think most, if not all of them, they all want to do. They want to work hard, and they want to perform and to be recognized for something in their field. But what is often lacking is the good opportunities, and I think this is the role of a teacher.
Yes, I think this is a very important question and is a very important issue to discuss. I think there is two steps. The first steps is try to convince neurosurgeon, neuroradiologist, neurologist that it is possible to develop endovascular by neurosurgeon. And this can be treated in different way, depend in the department we are working. But the second step is very important, is to have a recognition, to have acceptation by, in the medical practice in general in Morocco, that that endovascular can be taken in care by neurosurgeon. What so far it's not in the text of law. This is a big problem. And so now we can just give example. The cardiologists are taking care by all procedure, vascular procedure, endovascular procedure. The vascular surgeon are taking care of the patient with endovascular, except neurosurgeon, because there's something that has been inherited from the France, maybe politics from colleagues in France. So we have to work on that way at the university, but also at the legal level.
Thank you very much. I totally agree with this vision in our university in Marrakesh, Qadi Ayad University and Mohammed Siski University Hospital Center. All patients with vascular aneurysm treated are operated. We have no embolization. Surgery is done in 100%, but surgery does not solve all challenges and all problem. And I totally agree. We have to develop these techniques like in other countries, like Asia, for example. Neurosurgeons take care of all the pathologic disease. And I congratulate Professor Mahjouba for what she is doing, and the pioneer also for this vision. Thank you.
Thank you very much. I think it's very important for neurosurgeons to be involved in this endovascular work. We shouldn't be people who are repairing complications of others who are doing it. The way we're involved in spinal surgery, together with orthopedic surgeons, we should be involved also into endovascular work. I think very important because our vision of vascular surgery or vascular disease is completely different from the vision of radiologists. And I congratulate my brother and friend, Professor El Kamlishi, for having that vision. Right now, there is a young doctor from DRC, Congo, who is knocking on the door of Morocco to come here to do first general radiology, of course, and then neuroradiology, and endovascular or vascular radiology as well, so that it will be the first in DRC, in Congo, so that he can train others as well. So there is less difficulty for integration because there is nobody who is having the chair of that particular specialty. But it's very important that we are involved in this kind of interventions. Thank you.
I would also like to announce that for those who are interested in social program, for those who are interested in enrolling for social programs, please register your names at the registration desk. Of course, this announcement is not intended for residents. Residents are not intended to go for social programs during the course session. Okay? Thanks.
I think this is a good transition from this session, from the last question of Dr. Mahjouba. She will now continue with maybe to answer the question by in this symposium on endovascular procedure, technique, indication, and results. So Mahjouba, you take care of the symposium.
Thank you, Professor Wahabi. Thank you very much. I have to say that last time we were doing a case with Professor Khamlichi, he said I did an angiogram for him, and then he said, but I feel that you like microsurgery best, huh? And we were laughing at the OR because he felt that despite we are doing coiling and this endovascular techniques and so, but he knows that a neurosurgeon is still a neurosurgeon, and he likes I don't want to say blood, but CSF, which is water clear. So this symposium is. I want to emphasize something. The surgical clipping we can do both in the University Teaching Hospital, in the department with Professor Wahabi now, and also in Centre National de Réhabilitation et de Neurosciences. But endovascular techniques, until now, I only do this in Centre National de Réhabilitation, which means that we don't have an angio suite for me, for a neurosurgeon. The access is not yet easy, so this is part of the lack I was talking about. So I will divide my talk in three chapters. Let's say endovascular treatment of aneurysms, or procedures. I mean, this is a talk for a symposium for young neurosurgeons, of course, who want to know a little more about intracranial endovascular procedures, the tips and tricks, what they should look for if they talk to neuroradiologists or if they want themselves to practice one day. So I'm going to talk about how we treat aneurysms, how we treat AVMs and dural arteriovenous fistulas, and how we do thrombectomy. Because today these are the main procedures done either in the world or even in our country. So procedures in aneurysm treatment. Aneurysm coiling, whether it is assisted or not with balloons and stents, flow diversion, that has been a shift paradigm nowadays, with or without coiling, AVM and dural arteriovenous fistulas embolization, thrombectomy, and knowing that there are other procedures we don't do yet in our environments, that are the arterial stenosis stenting and the dural sinuses stenting, for example, for normal hydrocephalus pressure, normal pressure hydrocephalus. So endovascular treatments is, as you know, as that have been said already, is increasingly used. In some institutes, we know that it is the initial and even the preferred method of treatment. We can't hide this reality. It is there. It is just some kilometers away from here. The dream of a neurosurgeon, I can say, is to own an NGO suite for exploration and treatment. Thanks to Professor Khamlichi, I think I have one now. Ideally, a hybrid OR, and also to have a competence in interventional work for cerebrovascular disease. The treatment of aneurysms can be directed to the parent artery, whether we reconstruct it or we deconstruct it. The most used, of course, is the reconstructive techniques, which means the coiling, whether it is a standalone coiling, simple coiling, or a balloon-assisted coiling or a stent-assisted coiling, increasingly used, and other new techniques such as the neck reconstruction, etc. We can say the flow diversion, that is more and more used. The stand-alone coiling is a procedure that is performed under fluoroscopy. So you need your NGO suites and your table and your patients. It is done under general anesthesia. The access is your incision, or kind of, is from the femoral artery with a femoral sheet that can be a 5 or 6 or 7 French, and then a guiding catheter, what we call a guiding catheter, is preferably flushed with heparinized saline and nimodipine in a closed environment, because we don't have to have gas into these environments, closed environments. This is what we call a guiding catheter that can go through, this is the arch, aortic arch, and then you go with your guiding catheter, ou cathé guide, cathé porteur, until the artery, the carotid, internal carotid artery, or the vertebral artery, or the basilar artery. This is done under what we call road mapping, c'est-à-dire it means a subtraction, and this is a software. It can also be a 3D road mapping, and then you go with a microcatheter, and with this microcatheter you this is the case we did of a pericolosal aneurysm. This is the way we have to go sometimes very far until we reach this distal cerebral, anterior cerebral artery. This is a microcat and this is a microguide, and this is the way sometimes it's very tricky and it tends to go out and in, and we have to be aware of the possibility of rupture at this particular time, because we have, this is just because you see there are some, when somebody moves the table, sometimes you have to do again, but here it was quite easy to get in and to stay in. So this is the trickiest moment when trying to go into the sac. So you have to work with your hands and to torque until you get your guide wire, and then you can push or pull the guide wire and push the microcatheter, and this is then you, when you get into the sac, you very, very gently take out the micro guide. And then initially the first coil is called a framing coil. It is kind of a basket that you have to put into your aneurysm in a way that it forms a 3D volume that sticks to the walls of your aneurysm, and it has to be done gently, and it has to be done. The first coiling is the most important because you have some time to go back and forth until you reach a nice presentation of your first framing coil. The kind of coils is called as a 3D coil, a complex 3D coil. Then, so this is was for an MCA aneurysm, and here we can see some aneurysm. They can be oblong. They can have a very difficult volume. So sometimes you have to divide your aneurysm in two compartments, a distal compartment and then a proximal compartment, so that you can have two baskets, if you don't have assisted coiling with stents or with balloons. So this is the first coil, very important. Then after that, it's easy to fill with softer coils until the cavity is completely filled with coils, and until you have this kind of image, and you do at the end a final angiogram of the whole vessels to see if you don't have any problems during your procedure. The results are evaluated by some classifications that evaluate the occlusion of the aneurysm. So here you have a complete obliteration, here a residual neck, and here the residual aneurysm. This is from Raymond Roy in Montreal, and it was modified to see that there is a difference between having some circulation inside the coils or having literally a sac volume of circulation of blood into the sac. This class 3B is more probably more going more to regrowth or to recanalize. Here we have three example of cases. They were all 3A, which means this case with some circulation inside the sac, but with the framing coil, which is important, all around the aneurysm. You see the coil, how it is done. You see the circulation inside the aneurysm, but you see in the follow-up the whole aneurysm is completely occluded at 3 months. Here again, same thing, which means that we don't need to have this completely opaque, completely black at the first, because we can't put coils forever. We can't put more coils because the risk of rupture. This is other cases where we see that we have kind of an ear, a dog ear, what we call a dog ear remnant, but circulation of blood of contrast into the aneurysm also here. And these aneurysms, they did not complete occlusion at follow-up, so they needed retreatment. Also, we have complications. The frequency of thromboembolic events is going from 5 up to 30%, depending on the experience, depending of whether you put heparin or not, because of hematoma or because of a big grade fissure or something like that. So it's tricky and important. Also, thromboembolic events can be seen when we have assisted coiling with balloons and stents. Also, when we have long time procedures and large and giant aneurysm. Here is an example of a coiling of a basilar tip aneurysm with the thrombus that we see at the end here, protrusion of the coil, and also the obliteration of the right PCA. This is very careful. We in interventional neurosurgery or endovascular neurosurgery, we check every time, like with the microscope with IGC, we can check every time. It's a part of the job. And here, after injection of intra-arterial abciximab or other drugs, we can have recanalization of the PCA. Sometimes even without injection of anything. Sometimes we are lucky with the blood pressure, with working together with the anesthesiologist. He can monitor the pressure, the blood pressure. We have a very good neuroanesthesiologist that understands our friend Professor Amor and previously other professors that help us a lot in this with these things. And then at the end, you see that the thrombus is completely gone. Also, the complications, aneurysm rupture, which can be really devastating, but the first step is really like in surgery. Not here. You have an experience from just last week with this aneurysm. This was a patient, a young patient coming from Togo. He is Lebanese, coming from Togo. He came to our center because it was the nearest center to Lomé, and we had this aneurysm that is quite a rare aneurysm. It is a carotidocavernous aneurysm, a medial carotidocavernous aneurysm, but that has a transitional, it is a transitional type because it has bled initially in subarachnoid space. So we achieved, with the first coiling, we had this extravasation into the cavernous sinus with this cavernous, carotid cavernous fistula. The patient was then we have to just stay calm and do the coiling, finalize the coiling, and then do the CT scan to see if there is anything wrong, if there is a hematoma or something. But this patient was discharged at day 3 because he was doing very well, and his CT scan was really blood clear, and it was a fortuitous and a fortunate case, thanks God. So also in the results, we have to talk about recanalization and regrowth. Up to 10% of recanalization and regrowth, which, as Professor Araiz said before, unfortunately, transforms this pathology with the endovascular procedure in a chronical pathology, let's say, because you have to follow the patients for years and years, at least for 5 years, sometimes even less, before deciding to retreat again, either by microsurgical if possible, or recoiling or stenting or something adequate. Recanalization may not require treatment in half of the patients because during the follow-up there is no regrowth. We see these recanalizations with patients with the large neck, with wide neck, also with the patients when we have incomplete occlusion. So that's why we have to look to the control angiography after we send our patients to endovascular treatments, especially if they are done by radiologists. Not just because a patient is done, he has done his procedure in the OR, in the angio suite, means that he is okay. Sometimes we have incomplete occlusions. Sometimes we have very incomplete occlusions that are considered as patients treated. It is not like that. We have to be precise with our results, with ourselves and with radiologists. An incomplete occlusion is an incomplete clipping, so it should be reconsidered for treatment, especially if there is high blood pressure, if the patient is smoking, and if it is a location like the bifurcations or sites where we have high wall shear stress. Now, we can assist the coiling with the balloons. And the balloon is pushed towards the neck of the aneurysm. It is inflated and deflated at the moment of the controls, and it helps stabilize the coils inside the sac, not letting them bulge outside the aneurysm. This is what it looks like. So we have the it is non-detachable balloons that help a lot, but unfortunately these techniques lead to higher rate complications, thromboembolic complications, especially if they are not very well mastered. Now the stent assisted coiling is different, because you don't use a balloon that is temporary around your neck. You use something that is going to stay there, which is the stent. The stent is a kind of reconstruct the wall of the artery near of the aneurysm, and we have some techniques. Like this technique is the coil through Struts Techniques, which means that you push your microcatheter once that your stent has covered your neck or part of it. Then you push the microcatheter through the openings of the stent. Or what we call the jailing technique, which is actually you put first your microcatheter in your aneurysm, and then you close the door by pushing a stent. It means you jail your microcatheter and your coils. Here again, the total occlusion, like with the balloon assisted coiling, is better, is around 75%, but the rate again of the thromboembolic event is around 10% and is significantly higher compared to the coiling, simple coiling. Now, what about the flow diversion? What is it? What is flow diversion? From the first flow PED, a pipeline embolization device, was inserted in 2008 in the US. And I was in this department. I spent a 4 months fellowship in New York, where the pipeline was raised and used. So the pipeline or the flow diversion technique or the flow diverter is a thicker stent. It has small openings and a high pore density, and actually it diverts the blood flow. It diverts the blood from entering the aneurysm to going away to the brain, and little by little, this is what happens. There is a decrease in the flow activity, and there is a kind of an intimization of the stent of the flow diverter with the vessel, and then the aneurysm shrinks little by little. And at the beginning, flow diversion was only used for enruptured aneurysms and was only considered for one type of aneurysm, which means the cavernous, the carotid, internal carotid aneurysms, and the paraclinoid and ruptured intracranial aneurysm. Now, beyond the circle of Willis, they are used in very tiny vessels, such as the distal ACA and the MCA. And that was Professor Damien Bresson was saying. So much developments in endovascular techniques that it forces that we think about the future. And so that the flow diversion is nowadays the new frontier in endovascular treatment. It is used even in ruptured aneurysms. Its limitation is due to the dual antiplatelet therapy that we have to use, because the big problem with flow diversion is that it is a stent, it is a thick stent, so it might occlude. We can have a complete occlusion of the stent while we are doing the stenting. So the patient have to have a loading dose of antiplatelet therapy. The limits of flow diversion are sometimes in the ACOM A and the basilar tip, and the distal MCA is the unforgiving perforators. But still, we think, and the results are here to prove it, that the blood flow still
crosses the struts and the openings from the cell and preserves the perforators. This is one of the cases we did, I think last 2 months ago. So a big aneurysm you are going to see. There is a nice carotid, but this is stasis we have in this aneurysm. So we used flow diversion, and then it is not sufficient. So we usually do some coiling with the flow diversion, even if the patient is not ruptured. The aneurysm is not a ruptured aneurysm, because we fear that it can rupture, and this is possible before it completes the occlusion. We have this Okeli-Marotta OKM grading scale that evaluates the aneurysm filling after putting a flow diversion and the stasis phase. So you have different scales. You see if everything is, your aneurysm is still filled, so it is less satisfying than if you have just small stasis in the capillary or in the venous phase of doing an angiogram. All these things have to be considered before somebody can say or can tell you that we did the procedure and it's done. So as neurosurgeon, we are the doctors that take care of the patient, talk to the patients, take care of their complications, explain to them, and you are the residents who are in the ER in the nights, and so we have to know all of this. Thromboembolic events in flow diversions, of course, they occur, and also some hemorrhagic events like the late intraparenchymal cerebral hemorrhage in the ipsilateral side of the aneurysm. We have other devices. You have heard about the web, this kind of predetermined, fabricated devices that you can have lengths, you have diameters, and you can put them into your aneurysm. Also, this kind of devices that go only to the neck, etc. In conclusion, for coiling, for aneurysm coiling, we have the standalone coiling and a certain amount of complications. We have the balloon-assisted coiling, we have the stent-assisted coiling with some particular and specific complications due to the stent, to this for a lifetime inserted prosthesis, and we have flow diversions that nowadays can be used, but with a very careful. You have to be very careful with the use of antiplatelet therapy. I think before I go to the dural AVFs and the AVMs or thrombectomy, maybe if you have, because the main thing we are dealing with really is aneurysm treatment. It's not AVM or dural AVFs. The main thing is, and the more serious thing is the subarachnoid hemorrhage from aneurysm. So if any questions, I think we can maybe discuss before going to thrombectomy, and then some few words about AVMs and dural arteriovenous malformations. If you agree, if the audience agrees.
Thank you very much for this nice lecture.
Thank you.
I appreciate it. Do you inform the patient that the risk of stenting is 10% and probably underestimate, and that moreover you have a 3% risk of brain hemorrhage?
We have a modern practice of medicine in Morocco, so the consentement éclairé is very well taken very seriously in our department, since we are more and more dealing with low medical legal issues. So of course we tell patients, actually we don't do the flow diversion for simple aneurysm that we feel can do by clipping or simple coiling. The kind of patients we receive, not like in the series, in the international series, the kind of patients is this giant carotidocavernous aneurysm or ophthalmic carotidophthalmic aneurysm only. We have never done something that can be done with not only me but other senior colleagues easily. We have an experience about it. We never step into just because the patient said I don't want my head open, because we know that with the dual antiplatelet therapy anything can happen. We only use things especially that are very costly procedures. So we only do these costly procedures with the stenting and the flow diversion, very few, not a big series, when there is no other solution for our patients.
But I understood that you were increasing the indication with a smaller catheter, and
This is to the symposium is meant to explain, because not everybody we have. You know how the patients sometimes go to the radiology, interventional radiology suite, and he comes. The seniors we can look at our angiograms and we can say yes, this is occlude, but nobody understands from the residents, from the neurosurgery residents. Nobody understands the microcatheters, microguides, what is going on in the world. So the symposium is meant to explain and to explain technically, like if we were explaining about clips and things like that, and know what I mean.
Thank you, Professor Butarbouch. I saw one congress in United States about vascular that one researcher find flow diverter which will be incorporated by the artery. Did you hear about that? It should be like artery. It's not.
Is it different material? You mean?
No, it's biologic material.
Ah, okay.
It's
No.
not. It's not strange. C'est plus encore étranger. It's not in the commerce and just it's in the research. It's in order to make the artery as its origin. Do you hear about that?
No, I did not yet.
Vous avez entendu parler de ça? Vous avez entendu parler de ça?
There is some research about resorbable material. The purpose is, of course, the main issue is the thromboembolic effect and the need for B-antiplatelets therapy. So the purpose would be that you deploy a resorbable stent that should resorb in the coming months, and then you will keep only the antiplatelets for this period to prevent any delayed hemorrhage due to the antiplatelets.
Thank you very much, Shuva, for nice questions. And you have shown, I think, what we were saying just half an hour ago, that the endovascular is going to progress more and more also in our region. And should, I think, push all of us, and mainly colleagues now who are chief in the department, who have the chance to practice still 2/3 of treatment microsurgery, to teach more and more and more others who are coming. Because whatever is the progress of endovascular, we will need microsurgery. and we will need more difficult microsurgery. So I think that it's clear that what happened in other places in the world will come to us, it's coming to us, and this is very important, because if we lose this period of having today, I am always saying things in frankly way, of having today very good colleagues in different departments who are doing this vascular surgery as they have shown us. If we lose this period, the endovascular will come, and we will, our patients will be really in very, very difficult situation. Thank you anyway.
Thank you. Congratulations for your work. It's very important for a neurosurgeon to do this work. Est-ce que you did the web technique?
We never in our series we never did this, but I think they have the l'autorisation de mise sur le marché, and they did 2 or 3 cases, I think, in the other hospital where Professor Abedi works. Neuroradiologist, yes.
In Tunisia last week, Nadia Hamemi, you know Nadia Hamemi?
Of course, yes, in Tunisia.
The first 3 cases of web.
It's actually less. It's more easy. It looks like it's more easy than to be coiling for a long time. Yes. You only push your one device, and you deploy it like a stent, and it covers the whole sac. You don't need first coil in framing, second, third, fourth, sometimes 5 to 6 coils to have a good. You only put one, and you achieve with this one. It's like a cage. You achieve one, but it's costly. It's the cost of a stent. Yes. It's about 10,000 dirhams, which is a lot.
Okay. Thank you very much.
Yeah, it's a pleasure.
Thank you, Professor Mahjouba. Among criteria for treatment choice, do you take into account the patient's preference?
Sorry, I didn't hear.
Do you take into account the patient's preference for the choice of treatment?
You know, Professor Aitmani, all the patients, if there is a way of telling them or explaining to them. If you tell them you don't want your head to be open, right? They will all of them, they will say, no, I don't want my head to be open. But if you explain technically, scientifically, and if your patient is able to understand, you will give the rates, complications, things, evidence-based medicine. Say, until now we have this. You have to accept certain amount of perioperative rupture. Of course, I always, because I don't know when I enter, as Professor Azhari said, when we enter for an endovascular procedure, we never know. If we are going to have a dissection in the arch, if we are going to have intraoperative rupture with the cataclysm, we don't know if we are going to have a thrombosis of one cerebral. So all these complications, we don't want the patient to pay because it's costly. And then, as if it's something, of course really, sincerely, I'm not working alone. I have colleagues with me, seniors. There is Professor Wahabi, Professor Khamlishi in Centre National. So every case is discussed, and we can't just, because if I have one complications, patient should be aware of that. I have told him this, as every surgeon does. I mean, this is the difference between when we do it when you are a neurosurgeon. You have this weight on your shoulders to be as if you are going to do acoustic neurinoma or something. This is the difference between us, neurosurgeons, explaining this, and neuroradiologists in our environment. Neuroradiologists in our environment, they suppose the work have been done by those who admitted the patients, neurosurgeons. So they are only technical. Even if they have a rupture, sometimes you only know about the rupture when you do a CT scan, and they call the neurosurgeon. And so, of course, it's very important that, of course, it's a matter of honesty. If you're honest, it is something honesty, but also it's deontology, it's ethics. You have to follow. I mean, we have to do it. Even if sometimes you find something very easy and you think, with endovascular, maybe it's going to take me only 1 hour. But with microsurgery, it's going to take me 2 hours, you know, because of the OR. But we have to say to the patients, of course, it's vital to inform the patient.
Thank you. Thank you, Mahjouba. Thank you for your presentation. I thank you for two things. First, you have made a very balanced presentation,
of course,
showing, as I said by Professor Khamlichi, the complications of the endovascular, and this very clear message for the young, because sometimes they think that it's just a needle puncture, and the patient sometimes have this idea that it's just a needle puncture. Instead, doing that or opening a cranium, something very, very dramatic. So this is first thing. The second thing, I think that since you are doing both, and I know that you are a very excellent micro neurosurgeon, our colleague radiologists know that there is somebody that can discuss with them, knowing their problem, knowing there's insufficiency. So what I should say that since the introduction, the endovascular department, the number of cases we operated are more and more. And the last 10 years, we had 500 cases operated. So, because they know that you can say, okay, I prefer microsurgery than endovascular, because you can make a balance, you can judge both. And this is very important for the young. We don't operate because it is simple procedure. We should propose the best technique for the patient. This is my comment.
I would like to thank you, Professor Peterbush, for your very amazing presentation. I think that I have 3 questions. The first one is about the occurrence of a rupture during the endovascular procedure. Have you ever experienced it? And if so, what is the practical attitude in front of it? The second one is regarding the increasing amount of patient-treated endovascular and the consequence of education of microsurgery in the treatment of aneurysms. Leaving the more complicated cases for those people that are not yet accustomed to the simplest one. So the reflection is, beside the scientific indication, isn't any place to educational indication for an aneurysm that could have been treated endovascularly but purposely treated microvascularly to help young neurosurgeons be comfortable with simple cases before facing the more complicated ones. And the third question is about, I don't know if it's, I'm just curious to know if onyx has any place in the treatment of endovascular treatment of aneurysms. Thank you.
Thank you for your questions. First question, when you have a rupture, it's around 5%. You will around 5%. But if you are not a well-trained neuroradiologist, you can have anyway. I mean, it's in the literature. It's 5%. Okay. What you should do is keep the coil there. When you know it is a rupture, you know it because you feel it in your hands, because there is the wall is against your microcatheter, so you feel something, that you punctured something. Sometimes you don't feel it because it's just the coil that went through the fragility of the sac. So when you do the injo control, because the work of endovascular is doing injo control every time you do something, you do in control. So you see that there is a small extravasation, it's no problem. You can just continue coiling. But if it's a huge extravasation, it means that you are not yet into the sac. It's you can mount a balloon and stop, or you can just continue coiling. And then CT scan, and if necessary, you have to reverse the protamine. It's a whole process. It's a whole catastrophe. But still, I mean, many times we had some small ruptures, extravasation. We should continue coiling and just close the door of the wall. You close it tight. And then, but you have to be rapid and you have to be calm and know what's the region and what's you have to, because sometimes if you mega coil, then maybe some of the coils, they can go into the arteries, anterior cerebral artery, distal or something, so you have to be balanced. It's not an easy game. Second thing about the education, in our department, since the cases are done endovascularly from all over Morocco, they sent cases to Rabat, but with Professor Wahabi, we decided that we have to keep the microsurgery learning. And I can say we don't fight, but we discuss. And as we are less or more same age with the neuroradiologists, so we take the phone or we go to the OR and we tell them, I know you can do it endovascularly, but this case is good for also for clip-in. And now we are even thinking about we have to let them also develop the endovascular techniques. So we are thinking about maybe we do one day, if we have same aneurysm, we can do it both. One day, Monday is for you, and the day after Monday is for radiology. But it's always a discussion, and we are aware, very aware. And so we all neurosurgeons now in our department, they practice all in senior ones and medium senior, let's say, they all practice thanks to the tradition of microvascular surgery. We are not letting it away. No. So we are aware of this. PCOM, for example, Professor Wahabi can go with the let's say a senior resident and make him clip. This happened many times, and you know. So we are aware of this. 3, I think you said.
Is there any place to the use of conics?
Yes,
in the,
you know
the setting of aneurysms?
Yes, there was the teams from Turkey, from Ankara University and Istanbul. They used to have very large series of use of onyx. They put a balloon, they inject the onyx, and they have yes, the good series with good results and so. But it's a huge ball in the. So it's not a standard recommendation. It's not an evidence-based medicine recommendation. But there are some, of course, there are some series. They stopped now, I think. Takes more time. So I think I said it's only about the coiling. I'm going to be quick with regard to the thrombectomy and to the use of endovascular techniques in AVM and dural arteriovenous fistula. So I'm going to be quick. I know it's lunchtime. So je vais essayer de faire ça en 10 minutes. Je vais essayer de faire ça en 10 minutes. Very rapid. I'm going to try 10 minutes. Even it was intended to be half an hour. So endovascular treatments of the ischemic stroke in the acute phase is called mechanical, MT, thrombectomy mechanic, is called mechanical thrombectomy, and it is mainly used now by what we call the stent retriever. So this is the typical situation. Normal CT scan in a patient that has suffered from a hemiparesis or something. So you do the MRI. A flare doesn't show any hemorrhage, but you see that there is a penumbra. You go to the angio suite and you see this. there is a thrombus, you don't see your carotid artery, so you go with the devices and you take out the thrombus. This is what the thrombus looks like in a stent retriever. So you take it out. It's like a ramonage. Selection of the patients is crucial because it's a balance between the risks, which are hemorrhagic and thromboembolic, and the benefits. Only a minority of patients would benefit from mechanical thrombectomy, only 7 to 15%. Typically, it is a patient that has a small infarct, not a huge infarct, and due to a large vessel occlusion, not a distal occlusion. And of course, on MRI, what we call a penumbra, region that we can solve. So we have criteria of the American Heart Association to eligibility to mechanical thrombectomy. Superior or equal to 18 years old, in pre-stroke MRS normal, a patient that was normal, not too bad, any HSS, you know the score about the neurological deficit following ischemic events, and also the aspect score on MRI, which means that you don't have a large infarcts. So these criteria are, just to summarize, you can find them everywhere. We have many studies that have shown that it's very efficacious. Before we were saying less than 6 hours. You know that. Maybe you don't know, but today is until 24 hours you can do a mechanical thrombectomy. But the best time also remains between 6 and 16 hours. If a grandparent or something is coming from a far city or can still benefit from thrombectomy. But it has to be a large vessel occlusion with a small infarct and penumbra. So I'm going to make it short. This was the usual recommendation, 0 to 6 hours. Now 6 to 16 hours, mechanical thrombectomy is still recommended, and it is a class 1 evidence-based medicine. From 16 hours to 24 hours, it is still reasonable, and it is a class 1 level of evidence, B2R. Methods of endovascular therapy. You have the mechanical thrombectomy. You have aspirations. The mechanical thrombectomy have to be quick. Within 90 minutes from arrival of the patient to the hospital, it has to be punctured. And we have evaluation scores for what is going to be done. We have to be class 2B or 3 from MTC, modified score of the TC. So this is technical, just to show you that we also can have some systems of aspiration, but this is how it works. You push a guiding catheter, you push a microcatheter, you take out the guide, you push the stent, you go not blindly, but more or less blindly, but under fluoroscopy, of course, under road mapping. You go through the stent and you take out the stent very rapidly, and all the microcatheter and the stent through the this is how it works. And we have these 3 devices available in Morocco. We have Solitaire, Eric, and Catch Plus now. And complications, we can have hemorrhage, perforations, altercations with some drugs, dissections. So we have to be aware, and we don't have to spend a lifetime in doing a thrombectomy. If it is recommended that more than 5 times, if you don't succeed, you don't try more. And then we have complications events, of course, the non-TE, non-targeted embolizations. You can go for a thrombus here, and then find that you have embolized some microemboli everywhere in the This is what we can achieve. I already showed examples. So we really have a better prognosis with the mechanical thrombectomy in case of ischemic stroke with the thrombus occurring in large vessels, intracranial carotid and M1, as a matter of fact. This mechanical thrombectomy, it is a whole system that has to be better, to be beneficial to the patient. So that's what I wanted to say about thrombectomy. It's not, I hope it's not, I only have to say one word about AVMs. It's not anymore embolized. You have very huge centers in Europe when I was in France, and so AVMs was like a championship and heroes of AVMs, but now less and less studies about embolizations of AVMs. AVMs respond to radiosurgery very well, to staged radiosurgery also very well. We can embolize intranidal or perinidal aneurysms using coiling, but also if the AVM is very small and you feel like doing it, patients cannot be, has already had an hemorrhage or something and the vessel is small, you can still do with onyx more than glue. Now the glue brand, or what we use for our closure, Dural closure, is the same, so glue brand 2, we can use, but in our practice we prefer to do only dural arteriovenous fistula, no AVMs, because its results are not very good even in extensive literature. So we only use endovascular. That's a take-home message for me. If you have an aneurysm, I'm going to show you one case that we did, because he has an aneurysm, an associated aneurysm. Lots of complications, acute ischemia. The scenery of AVMs is, this is an AVM associated to this aneurysm, this pica aneurysm. Whether it is an association or fortuitous, we did this. In this case, we did embolization, but not for the AVM, only for the aneurysm. If you say the coils here. Then, the dural arteriovenous fistulas. There is one type of dural arteriovenous fistula that are mainly surgical, no embolization, no endovascular technique, which is the ethmoidal dural arteriovenous fistula. There is no discussion about this. This is just to make a reminder of what is a fistula. It is many branches, mainly from the external carotid artery, that can go, or rarely one branch, that go to a sinus. Whether you have an on-flow or a retrograde anti-flow or a retrograde flow, or even a venous cortical reflux that determine the severity of your dural arteriovenous and imminent treatment, you can use this time. The more used method is the onyx. The onyx has this capacity of going through the very far and precipitate in the fistulous connection, like here. This is a fistula to the sagittal sinus, fed by both external carotid temporal superficial artery. You can inject your onyx, but be aware of some complications like reflux in arteries of some cranial nerves, because you are dealing with feeder arteries from the dura. You can have some hemorrhage. Also the transvenous embolization that goes through a venous sinus. So in conclusion, for the coiling aneurysm is mainly it's the #1 procedure done all over the world, but for AVMs less and less. For dural arteriovenous there are some indications, and the thrombectomy is now the elderly pathology saver, and maybe we have to develop. It is now even done by cardiologists, and they are really interested in doing this. You know what? I was invited by the Collège des Cardiologues du Nord in Tangiers because they want to know what is thrombectomy for ischemic, because they deal with this kind of patients. And I felt a little bit jealous because the cardiologists, they have the people that go with the catheterism, they have the angio suite, so they can develop. And this is curious, or this is that we neurosurgeons can't have this angio suite in our hospitals for us, in our demand, and cardiologists can. So thank you for your attention, and I think yes, stomach is calling, stomach duty. Okay. À 15 heures. We start at 3 p.m.